All right, since it's just about 8:05, I'll get started. I do have a brief intro for you, Dr. Hameed, just for folks who don't know you quite as well. But our first speaker is Dr. Bilal Hameed, who's a professor of medicine here at UCSF. He's also the ambulatory chair of hepatology and the director of Fatty Liver Clinic. He has a robust research program focused on several critical areas within hepatology, including acute liver failure, which we'll hear about this morning, as well as metabolic dysfunction-associated steatohepatitis therapeutics and portal hypertension. He was the UCSF PI for the NIH-funded Acute Liver Failure Study Group, as well as the site PI for the NIH-funded NASH CRN and co-PI for the NIH-funded Liver Cirrhosis Network. His work has resulted in many impactful peer-reviewed publications. And on the fellow side, we know Dr. Hameed well by working with him on the liver transplant service, as well as rotating through the ambulatory liver clinics. Thanks for joining us this morning.
Thank you, Stephanie. Thank you, everyone, for joining. So, as you can see, the topic is acute liver failure. This is some of it's a rare condition which we'll talk about, but when these patients comes in, they will be the sickest and require the highest level of experience and monitoring. My goal in the next 50 minutes or 55 to talk about some of the aspect of management. These are my disclosures, but none related to the talk today. And for acute liver failure, it's mostly from MASH and PSC and cirrhosis studies. Um, what I wanted to discuss about, I know that many of you already know, but how do we define acute liver failure and the classification that we think how to define into different categories? What are the common causes of acute liver failure? We would not have time to go into individual. I will talk mainly acetaminophen and some of the other causes which I feel they come into the GI boats and liver boats a lot. So focusing on that, what are the primary indicators of prognosis that we can say how this patient will gonna be doing based on different risk factors and how they're doing? Other and what is the basic element of supportive care of acute liver failure? How we think as holistically when these patients are in the ICU. So I'll start with the case, and these are all real cases that we have seen in the last, since I've been here. So this is first is a 22-year-old patient with no history of liver disease, started taking acetaminophen every 2 hours for headaches. Went to the emergency room for abdominal pain, nausea, vomiting. Lab shows here INR of 3.2, ALT and AST are elevated as expected for Tylenol-related liver injury. Transferred to UCSF, and when we came to our service, patient had completely virtual normal mental examination. Patient was fine and no asterisks. So the first question many of you on, and that always good to remember, does the patient meets the criteria for acute liver failure? And the point always to bring it up that the presence of hepatic encephalopathy is important to make the diagnosis. So when we diagnose or the definition of acute liver failure in patient without any pre-existing liver disease, development of coagulopathy, which is INR greater than 1.5, and the presence of hepatic encephalopathy. If patient does not have hepatic encephalopathy and the INR is 2.0, we call it acute liver injury, not acute liver failure. Very commonly, there are patients who are coming in, and also the differentiation has to be from acute on chronic liver failure. There's a lot of, many times I see patient with acute on chronic liver failure and medicine team is writing acute liver failure. That's completely different because the management is different. How we list them for transplantation is completely different. To further about, think about that many of these patients will have acute hepatitis with AST, ALT minimum of 5 times, but it is normally much higher. Occasionally, we get call on consult service. The AST and ALT are completely normal, but INR is elevated, and they're calling them. So that is also have to pay attention. The ALT, AST has to be very high, as we talked about coagulopathy and encephalopathy. No pre-existing cirrhosis. The only exception that there are some patients with Wilson's disease or autoimmune hepatitis that can have no prior history of liver disease, but they may have advanced fibrous cirrhosis, but that's their first presentation in acute, and they will be still considered as acute liver failure. So those are a couple of exceptions. And the duration of illness ideally is less than 26 weeks. There is some differentiation in different criteria between APASL and EASL, but 26 week is between the onset, and that's how we define the different categories, which I'll mention in the next few slides. Now, the word, people have used fulminant hepatic failure, but the word we is for our study group is acute liver failure. It's a super orphan disease, but the most severe form of liver injury. In the earlier, data that there are about 2,000 cases per year, so it's not that commonly that we see. Before a better ICU care or liver transplantation, survival was very poor. It is very fascinating, sometimes very frustrating because we don't know what the cause of liver failure is, and then very difficult to study. Many data are kind of present. These are our prospective observational studies. It's very hard to do randomized control. We did some like ammonia lowering agent, but enrollment of those are very, very difficult. So let's talk about further classification of acute liver failure, and I'll explain it to you why it becomes important. The one is hyperacute, the second is acute and subacute. Like you can see, hyperacute are patients who are less than 1 week of presentation. Most of those cases are APAP, and that's the number one, right? Then hepatitis A and E can present with that, and ischemia can present with very acute hyperacute. The acute is 7 to 21 days, and hepatitis B, some other cases like Budd-Chiari can also present, sometimes Wilson's. And subacute are patients who have a prolonged course. They are outpatient, their liver tests are going up, they were taking a medications, and then after like 3, 4 weeks, they are presenting and now getting sicker and sicker. And it's mostly drug-induced liver injury or some other cases that we have seen, like autoimmune hepatitis can present with subacute. And the reason it becomes that, when we discuss about complication, how these patients have high mortality is number one is cerebral edema. And the hyperacute cases is the highest risk of cerebral edema, but at the same time, they have a better prognosis. If you manage it, they have a better chance of um, improvement without transplant on their own. And then patients who are subacute, the risk of cerebral edema are lower, but then they have a very high chance of high mortality if they don't get a liver transplantation. So that's how sometimes the differentiation, although we don't put it like, but just for your clinical sense. And since it's like in some of the guidelines now, also, although we knew about it, it may come in the board. So just wanted to make sure you are aware of it. Now, important distinctions are obviously acute and chronic liver failure. As many of you know, those patients have already chronic liver disease and now acute deterioration. Acute liver injury, this is a term we coined through our network. And those are the patient, again, they can be, mostly they were Tylenol or acetaminophen related, but there are other. When they have very high ALT, AST, INR was greater than 2.0, that's the definition used, but without encephalopathy. And many of these patients, there's less chance of progressing to acute liver failure, especially with Tylenol. If they come to you without encephalopathy and you started NAC very early on, unlikely they will progress. Except that, there are some cases of drug-induced or hepatitis B or autoimmune, they can have a chance. And then at the same time, there's some secondary liver injury. You get called in the ICU patient is like metabolic encephalopathy, INR bilirubin, and they're calling it acute liver failure, but they don't have a primary liver insult. So you need to differentiate from those cases. Now, let's talk about a second case. A 22-year-old with altered mental status to a local emergency room, no history of IV drug use or prior liver disease. Patient jaundice clearly has asterisk as an acute liver failure. This time around, bilirubin was 25, INR 2.4. Acetaminophen level was not detected, and they did like, in the ER, some preliminary viral serologies, pregnancy test was negative, tox screen was negative. So which one is the following you would recommend at this time? So this is very classic board question that comes in. You worried about because acetaminophen level was negative. You consider like starting steroids for a concern for autoimmune hepatitis. You don't know the cause. You liver biopsy. You start acyclovir for concern for herpes hepatitis or transfer to a liver transplant center. So the point of this question is always that, these patients with acute liver failure who has developed hepatic encephalopathy and with asterix is a grade 2, these patients need to be in a liver transplant center. That is, I think, so many time when in the board question, they're trying to understand all these other things. You can think about it, but transfer to liver transplant center is the key in this scenario. So anytime you have a patient, or at least calling the liver transplant. So if you're in the other hospital covering or in the emergency room, they call you, you should call that liver transplant place and say that, this patient with acute liver failure, and that's all you need to say, and then discuss about whether the patient needs to come here. So the answer here is transfer to liver transplant. Now, when we talk about the causes, and we'll kind of talk more about some of it, and this is also not a complete list, you can look at it, that is, but these are some of the main causes of acute liver failure, with whether it's hepatitis, acetaminophen, Wilson's, Budd-Chiari, drug-induced mushroom, autoimmune indeterminate was about 15 to 20%, herpes, ischemia. But when the acute liver failure happens, just like cirrhosis, decompensation, the outcomes or effect will be the same. And the two biggest thing that beside the encephalopathy and risk for cerebral edema and coagulopathy, these patients, majority of them also have a renal failure. They have very high risk of infection, risk of bleeding, and they can present with shock. So the effect will be very similar. So therefore, we are not only managing their acute liver failure, we're also deciding at the same time whether we should proceed with listing for transplantation, whether this patient will be getting listed in a very quick manner within like 24 hours. We have to make these decisions. Now, another case of 18-year-old patient this time around with history of drug use started having episode of binge drinking on New Year Eve. Initially, patient was tired, then developed nausea, vomiting, right-sided abdominal pain, and become very sleepy. Next day was confused, disoriented, agitated, calling people by wrong names, talking to objects, so clearly pointing towards hepatic encephalopathy. Patient had asthma, binge drinking, acne, substance abuse. We don't know whether there was suicidal thought. There was one roommate who was there talking about it, and albuterol and ranitidine. So nothing like, major. Patient lives with a roommate, no history of autoimmune or liver diseases. And so the question is, what is in this young patient is the likely cause of acute liver failure? And the point of this question is that what is the most common cause of acute liver failure in a young person that you see in the West or in the US? And many of you know the answer would be the answer, and but these are understanding that if sometime you don't know the exact, like the complete history, many of these patients, the history is very unclear, don't know what they're taking. But sometime with the history is that majority of these cases, more than half of the cases that we see is acetaminophen related. And that is something that we see all the time. In fact, in our network, there were some indeterminate cases that we went back and we had these research adduct for APAP, where it can be positive for up to 14 or 21 days in urine and now developing into blood, was positive later, and there was nothing in the at that time the level was low. So the most common cause of acute liver failure in the US is acetaminophen. Any young person that's coming in, unless you have any other cause of it, you need to think about it. And this is our acute liver failure study group, which almost for 20 years recruited from all over the US. And this was their last, like when we finish our enrollment in January of, this is the last data. And if you look around that, around 1,100 patients from this network, or 46% was APAP. And 12% was indeterminate, and half those indeterminate cases also was APAP later when we actually went through very extensive deliberation. And after that, other drugs beside APAP, which are drug-induced liver injury, was 11%. Now we do think about other rare causes of it, but autoimmune hepatitis, there's ischemia, hepatitis A, and hepatitis B, which less common as other causes, especially. So that is something that and then you have, other causes which are like shock liver. Beside the shock liver, we have these heat stroke. In fact, we have recently a patient, young person comes in with heat stroke and mushroom. We see those cases. But the point is, acetaminophen is still, unfortunately, continues to be the number one cause of acute liver failure in the US. And if we think about worldwide, and this is a nice like review article, although almost like about 12 13 years back, that it was in New England Medical Journal, they tried to ask, and this the data with acetaminophen here may be a little bit different, 39, because it's not the study. They asked the expert about what your cases is individually, and how I think about it, that in the West, like if you look at it, acetaminophen is still the biggest cause of acute liver failure as compared to someone from other part where viral hepatitis has been. So India, Bangladesh, and other places, you see a lot of hepatitis E. So the history becomes very important. And in Japan, is hepatitis B is a big part of it. Here in the US, we see some like around 7% to 8% where the reactivation of hepatitis B. So viral hepatitis in that part, and acetaminophen continues to be a big part in the US and the West. Now there's extensive list. You don't have to. Just the point of the second common cause, as we discuss, is drug induced. Almost most of the medication and antibiotic, and sometimes we take some of these medications for granted, like Cipro. I have seen a case of Cipro-related acute liver failure. Doxy, we know about it, and so other like Bactrim and medications. Although the anti-epileptic is can cause it, when I was in Pakistan, we used to see, TB is prevalent, and I had seen many cases of INH-related acute liver failure. We had few in the US when, especially an elderly person recently was started INH and developed acute liver failure and transferred to us. And obviously, herbals is a big part of it. We know Kava Kava Herbal Life, but there's a whole list of it. So getting that history becomes very important, and the etiology is important cause of how these patients do. Most of these drug-induced liver failure, if they develop hepatic encephalopathy, the outcomes are not good, and many of these patients will require liver transplant. So look at every list, talk to the pharmacy, go to the liver talks, and if the patient coming in with acute liver failure. Now, acetaminophen, as I mentioned already, continues to be a big problem. This was a nice study from our network. What they tried to look at it from, because we were supposed to provide the data to FDA every year about how many cases. And the point is that every year, despite a lot of information and knowledge and some of the changes that we try to do with FDA, like how much acetaminophen and these like narco preps were there. And it's not always that you think about that these are the patients who are trying to hurt themselves or suicide attempt. There are many what we call therapeutic misadventures. They were patients taking multiple opioids preparation, also taking acetaminophen, but the outcomes are the same. It doesn't matter how you reach the point of acute liver failure. So it is consistently the same. And this is back to how the acetaminophen does cause acute liver. And many of you know that when you take APAP, many of those patients have a level has to be around 10 grams or so, high amount, before they develop this acute liver injury or liver failure. Except there are patients who also having alcohol, because alcohol also fight with the same enzymes for APAP metabolism. So majority goes into the glucuronidation and sulfation pathways, and about 5 to 9%, which is left, use the cytochrome P450 enzyme in the liver and change into NAPQ1, which is quickly taken up by GSS transferase and change into mercaptopuric acid. But the remaining one, if they have a very high amount, will get into this adduct, that NAPQ1 protein adduct, which cause mitochondrial oxidative stress and also ultimately lead to hepatic necrosis. And so obviously, if you take a lot of acetaminophen, and this will overcome the cytochrome P450 and lead to this hepatic necrosis. And this same toxic metabolite is also renal toxic. So most of the patients who are coming with acute liver failure and already developed like severe encephalopathy will have acute kidney injury. In fact, if they have not developed acute kidney injury, I was wonder the diagnosis of Tylenol as a cause of it, or APAP. Now, history is very difficult in these patients, but you have to suspect. That's what the point of having this, my concern, that you have to start the treatment right away with NAC. Families are aware, and then we develop this, although it's no brainer, but majority of these patients either some history of APAP or taking something for headache. There may be some detectable level. You don't have to be very high level, but if they are even any detectable level, plus the ALT/AST will always be greater than 1000, and the bilirubin ideally I feel is less than 10, less than 5, right? They don't have high bilirubin, but less than 10 is where we call highly or likely definitive case of APAP. Now, as no everyone knows about the management, this is not something new. Since 1970s or even before that, N-acetylcysteine has been used for in the UK it's called paracetamol, or other part of the world is acetaminophen here, that is accepted antidote worldwide. And initially it was oral, now we have IV form available. And then the question that comes in, how it helps with NAC, helps in patient with APAP. There are different theories, and some studies have done that. First of all, it replenished the GSS to enhance detoxification. It also have protective effect during that oxidative injury phase, and then also supply energy substrate for Krebs cycle, so that hepatic ATP levels and improve mitochondria. So these are the three theoretical and some like lab things that they have found out, that's why. And this is the same reason when we will discuss about N-acetylcysteine for non-APAP cases, that some of these things are helping with the Krebs cycle and hepatic ATP and mitochondrial function, but have a very narrow therapeutic window, and therefore it can, when they come to the emergence, start right away. And that is a very important thing. And many of you have gone, normally pharmacy comes up. We only use, like, to be honest, IV. There is an oral form, but with nausea, vomiting, I don't use it, or we don't use it at all. There is, over the period of time, and there is an extended IV protocol. Now, the question that comes in, that in patient with APAP, acute liver failure, that you continue the APA, N-acetylcysteine, either they have an outcome, but when do you stop it? And there's a different in experts' opinion. There's no studies done. Some have used, like, INR of less than 1.5. The other have used like ALT decreased by 50%, but many of us, like, have it that patients are clinically improving. The ALT is less than 1000, INR less than 2. If the patient has hepatic encephalopathy, then we can stop it. And there's nothing. So that's, I think, the one clinical thing that a lot of time that the resident and fellows ask us. And there's only one expert, like, Bob Fontana at Michigan. Also, he use mostly the INR of less than 1.5. And the one other point is that when we talk about non-APAP use of N-acetylcysteine, you just basically use this IV protocol of, like, use it the overall, like, about the 16 hours, the third back, and you stop it. So in patient with non-APAP acute liver failure, you don't continue it, as compared to APAP, where you continue. Either patient had this improvement or get a transplant or other thing. Now, the take-home message is for APAP related, that patients have very high ALT, AST, and low bilirubin. You always give NAC, even if it's in doubt or anything. Many of these patients may have some underlying, drug use or underlying mental health issues. And renal injury is very common in patients, especially with encephalopathy, in the ICU they will have. And transplant listing must be undertaken ASAP to decide whether you transplant or not. They have a good chance, but with the cerebral edema risk and other things, they can get really sick within a day or so. So you need to decide if patient is a candidate for transplantation or not. Now, a few other cases, hepatitis B, also we see it's about 8% of ALF cases. However, only less than 4% of acute Hep B will develop ALF if you pick early and start the medication. Now, many of those time, we hardly see de novo infection as a cause of it. It's like mostly reactivation. And unfortunately, mortality is very high with reactivation if you don't pick it up, and many of these patients will need. It doesn't matter if you have a suspicion of anyone coming in, you start tenofovir or entecavir. Although my preference is tenofovir because I feel that it just, like, may have a viral load decrease. But many of the time, the viral load, even if it's decreasing, if the hepatic necrosis already happened, may not recover. So, but you have any suspicion, you always start the medication tenofovir or entecavir, and then wait for all the serologists to be back and decide whether to stop it or not. Now, hepatitis A, we have recently seen more outbreaks. Fortunately, many of them has acute liver injury or just hepatitis rather than liver failure. And only less than 1% develop acute liver failure, but it's still one of those things that you always have to pay attention and get the history. And if there's outbreak. Now, herpes is very important to remember, although I have seen even in without immunocompetent patients coming in. But the examination is important. The skin examination finding can be only, although seen in 50% cases, but still have to pay attention. But any doubt, if there is no clear history of acetaminophen, other thing, we do recommend starting IV acyclovir right away in a young person, right? So that you can at least cover it because the mortality is so high in these patients, they can get really sick. And then you wait for the herpes PCR, and by the time it comes in if negative, you can stop it. But also the point is have a low threshold if you don't have, especially in a young person, a pregnant patient, or someone immunocompromised. You don't know the cause of it, just start IV acyclovir, and then you can continue and stop it once the herpes viral load is back. Now, hepatitis E is very interesting virus. The reason I added up, you may not see a case, but they love it in the GI boards or other. And especially there will be a history of someone traveling for that part of the world. And the second is there is a vertical transmission. And in patients who are pregnant, the mortality or fatality rate is very, very high. It's up to 15 to 25% as compared to in overall population. And there's an unclear mechanism why this fatality or mortality is very high in pregnancy, but this is something real. And so hepatitis E. Now, interestingly, in India or Pakistan, there's a huge cirrhosis population. Hepatitis E is one of the most common cause of acute and chronic liver failure. So patient with because it's such a common thing that patients compensated cirrhosis or liver disease and suddenly they get hep E and they develop into acute and chronic liver failure. Now let's talk about how do we diagnose our history. So it is important history in these cases, and how do you pay? You always try to search for the etiology, so you ask all these questions, and get and many of you already. The only thing is I didn't mention mushroom because of the time that most of the patients with Amanita toxin has it's a GI toxin, so any board question comes in nausea, vomiting, diarrhea, and acute liver failure. It's they trying for you to think about mushroom as a cause of it. So you talk about GI, and then also identify patients who have had acute fatty liver of pregnancy in pregnant. Patient has traveled anywhere, certain risk factors. If anyone has received immunosuppressive biologic chemotherapy, you may not. Sometimes the Hep B core antibody may be falsely negative. So you just start the treatment, wait for it. If there is a family history of autoimmune disease, you think about autoimmune hepatitis. And so this is something very common that you think about it. Now, when we look at the clinical feature I had mentioned, but as I already said, these are the sickest patient. And in brain, beside in any chronic patient with hepatic encephalopathy, but they're patient with acute liver failure, since the liver is fine, there is the risk of cerebral edema and intracranial hypertension is very high. And we'll talk briefly about when we discuss about the management. And in liver, because many of you know the gluconeogenesis will be affected. So these patients can be profoundly hypoglycemic, and therefore we use dextrose if the blood sugars are very low and monitor their blood sugar. They can have severe lactic acidosis. They have a very high ammonia, and then we check arterial ammonia that is correlated with their prognosis and cerebral edema. And obviously they will have coagulopathy. Now, a few other things I wanted to mention that there is in one of our acute liver failure study group, the risk of pancreatitis, at least a biochemical pancreatitis up to 20%, the lipase will be elevated. And some patients will have clinical pancreatitis and the management becomes very hard because many times with acute liver failure, we want them to be intravascularly dry to make sure the cerebral edema does not. And if they have pancreatitis, how do we monitor? And we have seen our ARDS also, as we talked about renal failure, especially AKI with acetaminophen is very common. And lastly, in someone with a viral autoimmune, it's not uncommon that you see low platelet counts and people are thinking maybe they have cirrhosis. Even when you do an ultrasound, because of the collapse or necrosis, the radiologists sometimes say, oh, the liver looks cirrhotic or there is mild ascites, and you're thinking about, the patient have chronic liver disease. So don't, get sidetracked by those things. They can be finding that you can still see in patient with acute liver failure. Now there are different checklists. If you look at our workbook, and when in a first year fellows, when you're coming to second year, the LTU workbook has this checklist. There is also a nice paper that out there where you can look at the checklist. But this is basically assess the severity of it, and we will talk about some prognostic marker. We do an ABG and arterial ammonia at baseline. Then you look for the causes of it. You check all the viral serologies and other things to make sure that you have everyone get an ultrasound Doppler, make sure PET KRE, and if you worry about, you can do additional testing. And as we talked about, lipase and amylase for complication and blood cultures, risk of infections are there. So this is just, and then these slides will be available for you anyway, whenever you wanted to go and look at it. So now when we talk about the prognosis and how we think about the next is about the prognosis. So think about which of these following patients will need a liver transplant, meaning they would not recover without having a transplant. A 53-year-old patient with APAP liver failure with INR of 2.0 and mild confusion, a 59-year-old with latent TB on INH for 8 weeks, now with jaundice, hepatic encephalopathy, and INR. So it's like, subacute presentation. A 22-year-old third trimester of pregnancy present with 3 days of nausea vomiting. INR is 1.9 and a slow mentation. And a 66-year-old with heart failure, AFib, now with hypotension, ALT, AST, more AST elevation, bilirubin 6, INR, so shock liver or ischemic presentation. So which one of these patients, 1, 2, 3, 4, will likely need a liver transplant or will not recover without a transplant? So the point is that the etiology is an important factor in determining how these patients will gonna be doing. So anyone has a take, like, what they think is the most likely will need a liver transplantation out of those 4 scenarios? So let me just see. So the answer is number 2, the patients with. And the reason I can explain in the next slide is the etiology and how they're doing in hepatic encephalopathy point of view will be important. So when we take all the patients with acute liver failure, the overall survival is around 70%. Half of them will have a spontaneous survival. You manage them well, make sure the other complications are managed, and then about 1/3 will need a liver transplant. And 1/3, unfortunately, will die without a transplant. This is like, in acute liver failure study group, and that is. So survival becomes like 70%. So the first thing that we always talk about is what is the cause of acute failure or prognosis is based on etiology. And we divide them in, as I mentioned, with this hyperacute cases like less than 7 days, which is APAP, hepatitis A, ischemia, and acute fatty liver pregnancy. That consider, so if you take these patients coming in, 80% of patients will have a transplant-free survival with APAP. Hepatitis A has a good one. And I think it's much more higher. I don't know what happened with some of the centers when you look at the data, ischemia and acute fatty liver pregnancy, almost 90, 100%. But as compared to patients with hepatitis B, autoimmune hepatitis, drug-induced, and indeterminate. So, but the point is, these are all patients who already develop hepatic encephalopathy. We're not talking about autoimmune hepatitis, Hep B, who doesn't, and acute liver injury. These are the patients who are coming with acute liver failure. So once they already develop acute liver failure with Hep B, autoimmune drug, or indeterminate, their prognosis is less, without transplant-free survival is low. So that first thing is the etiology. Now, second thing that comes in, so these are the, patients we care like, poor prognosis, and that's when I'll show you one of our prognostic calculator. This is also taking into consideration. And beside the etiology, what is the second most or other most important prognostic factor in acute liver failure? So I think that is where the hepatic encephalopathy or coma grade comes in. So the first is etiology, and the second one, what is the coma grade by the time they reach a transplant center or reach you, right? And then the grade of hepatic encephalopathy, many of you know, and then it's important to make sure that there are patients who already had stage 1 or grade 1 hepatic encephalopathy, and we are waiting for asterisks to develop, which are basically all happen in grade 2, but patients can have like changes in behavior and sleep cycle. And the definition of acute liver failure is any hepatic encephalopathy. It's not something that you need to like wait for the grade 2. And then for the purpose of acute liver failure, we normally divide early, which is grade 1 to 2, and severe, which is 3 and 4. So that is how we differentiate how these patients do. And then if you look at the same data, which I was presented before based on the etiology, now this is the data based on when they are presenting to you, whether they have early grade 1 to 2 hepatic encephalopathy or they have already developed severe. So bottom line is that patients who are coming in early grade 1 to 2 have 50% better survival than someone who's coming late to it. And so that's why Even in patients with acetaminophen, many of the time when they come to us and they are intubated, other they're very severe, those patients have 50% outcomes, if they spontaneous survival or transplant-free survival, and those patients are the one we believe that quickly they would need a liver transplant. Same with even if they have acute fatty liver pregnancy, if they have severe hepatic, that you have a 50, the transplant-free survival is 40%. So we are making that decision day by day if to proceed with a transplant in these patients or not. There are a lot of other prognostic indicators in acute liver failure, which many of you already know. The two things that we have it are like King's College. MEL score has been used, but I don't like, MEL score that much in acute liver failure. But they say if there's someone MEL of greater than 32, there's a factor 5 and Cliché criteria. But the one thing that we have developed is also what we call acute liver failure study group model, which has etiology, the vasopressor use, what is the bilirubin and the INR and change in INR into it. Now, everyone needs to know King's College still have the sensitivity about 60, about 70%, and specificity is very good. Although it's like in 80s, but still well used, and everyone needs to understand. You don't have to memorize it, but to know that. So in patients with acetaminophen, if you have severe lactic or severe acidosis after correction of early or hypertension, or if you have an INR of greater than 6.5, creatinine 3.4 or grade 3 to 4, if they have all three things, this patient will need a liver transplantation. So that's how they feel that this is good for the listing criteria, especially in NHS. They develop because not every patient can come to big transplant center. Now, non-acetaminophen is any patient has an INR greater than 6.5, it's a poor prognostic, and that patient likely will need a transplant. And then it's A, B, C, D, E, right? And then a very early age or greater than 40, if your bilirubin is greater than 17, if your INR is greater than 3.5, the duration of jaundice, like what they're thinking about more acute or subacute, not hyperacute, or etiology is non-Hep A, non-B, or drugs or something like, those patients, if they have this part of it, they likely. So again, etiology is part of it, and then that is something that they are taking into consideration. So ALF ASG prognostic score, it's actually available in iPhone and iTunes. You can download it and you just write LFG prognostic score. It just predict 21 day spontaneous survival. And we had a validation developmental cohort and then a validation cohort. And it actually fared really well. The area under the curve was pretty good, zero point 0.8 as compared to other King's College and MEL score in that regard. And what it is, so this is going to show up on your in your calculator, and obviously everything is taking into when the patient comes in and what other thing. In fact, when we were actually doing this study, the PI, the principal investigator, clinical experience in telling them this patient will need a liver biopsy was as good as any prognostic scores. So that is. But they ask you whether the patient's hepatic encephalopathy, what is the etiology, and the etiology will be favorable will be acetaminophen pregnancy ischemia and Hep A. I already mentioned that. Whether they are on vasopressin, what is the bilirubin and INR. So this was the real patient that we had it. Who had some kind of bodybuilding supplement he was taking, and then had a very severe hepatic encephalopathy, which means that he has an unfavorable etiology because he was taking it's not APAP other. He was on vasopressin. Bilirubin was 5, INR 6. So his predicted spontaneous survival was around 4%. Although when patients get off of like vasopressor or something, then it can be like 20%. But it just shows that these are give you an idea this patient need to be discussed and transplant and be listed. Now, in the last 10 minutes or so, we'll talk about overall principle of care so that you have. First of all, you would not be believed there are patients with acute liver failure, no one is paying attention. We had cases that patients on a floor, no one paid attention, they had acute liver failure. We had like a couple of years back, I had a patient calling that came in like a couple of times to the emergency room, and then they thought that there's a gallbladder issue. ALT/AST was like 2000 INR. No one checked the INR, and they were taken to the gallbladder removal, and patient was like comatose after that, and patient came in with acute liver failure and now had a surgery, and we had to transfer and patient and transplant it. But these patients need to be in the ICU because it's a severe, rapidly progressive multi-organ. So you not bring them on a floor. Sometimes we get call or patient on the floor. And then, as we already talked about, early transfer to the or calling the transplant center, We don't just transfuse for INR alone, as we very well know that this is, and we intubate. I do intubation for grade 2 unless something else. So you have an early intubation is the key because you may want to make sure they don't have increased intracranial pressure, and obviously there's no substitute for experience. Now, one point that this was a study also in 2009 trying to identify whether the N-acetylcysteine improved transplant-free survival with non-APEP cases. And it's not a big study, but what it came out of it that if the patients in early encephalopathy, if you start the NAC in patients with non-APAP and they are grade 1 to 2 hepatic encephalopathy, there was a statistical significance in survival. In the later stages, overall, if you look at the survival, there was no difference into it, but you divide it with the grade of hepatic encephalopathy, there was a difference into it. Similar study in children did not show any benefit, but that is the study, and there's some others like smaller study shows that. So you can use APAP, and we recommend using APAP in even NAC in non-APAP cases. However, the only caution I would just pay attention that, if someone has ischemia or shock liver or heart failure, you have to pay. I don't think so that will gonna help in those group of patients because I've seen it and the volume overload is a concern with non-APAP. The data is good, but not as great that you would use it in patient with volume overload. Now, there are some like specific therapies which we already had briefly discussed about. Silibinin and penicillin G, the data is not very clear. But the point is, one thing that any pregnancy as a cause of acute liver failure, the answer is always delivery. So you have to deliver. Get the OBGYN, that's a board question. And Wilson's disease is transplant, although they talk about plasma exchange and plasmapheresis, you can use it. Now, one question, clinical question people ask us in autoimmune hepatitis about corticosteroids. Or my thing, and there's an expert opinion, if in autoimmune hepatitis they already develop hepatic encephalopathy and in the ICU, the steroid will not help them by that time, unlikely to help them. There's increased risk of infection. Most of these patients are acute liver injury, they have ALT 2000 but have not developed the steroids, have a good chance of helping them. So that is something that you always pay attention to. And so I say, like, overall, knack for everyone. We start renal replacement therapy, which I'll discuss about why early in these patients you do intracranial hypertension prevention. The data about prophylactic antibiotics are not great, but if these patients do develop liver infection or any infection, sorry, not liver, they have a very high mortality. At UCSF, we use moxifloxacin as to start with, and although we don't have that data to prove it, dextrose and enteral feeding, and we already talked about ICU monitoring and intubation. Now, why intracranial hypertension? It does correlate it with grade of hepatic encephalopathy in patient with grade 4. Up to two-thirds of patients will have a risk of developing intracranial, and it's a cause of death in about one-third, about 25 to 35 if you're not paying attention. Obviously, the risk factors are acute or hyperacute or acute. If they have younger age, if they have renal impairment, if they need iotronic support, and if the arterial ammonia greater than 200, the risk of intracranial hypertension, and that is as compared to our chronic liver disease patient where the ammonia we don't check. This is important, but the data is on arterial ammonia. Now, I'll just skip. This is the patient I had like early on when became a faculty. Had an offer for transplantation. It's also drug induced, and unfortunately, patient had this like you know you don't need to be a neuroradiologist to think about this patient herniated. So this is a real, and we have seen cases. So at UCSF, we don't wait for intracranial hypertension. We start treating them as they already have intracranial hypertension. And some of you who have worked with us in that and have. So the important thing is fluid management with CRT. You make them intravascularly dry, minimize head of the bed at 30 degrees, permissive hypothermia. And then we do try to keep the serum osmol in someone with intubated and grade 2 to 3 higher hepatic encephalopathy around 300 to 320 minimal serum. And then we try to keep the sodium level around 140, 150, 155. Propofol is actually good, it had seizure and also decrease intracranial. Hardly we use like barbiturate coma. You don't manage their, like, we don't can follow the mental status. So I have not used it. There was one. So, but this is like what you ideally start CRT early. We give them mannitol, hypertonic, and then keep going. And we don't do like if the question is intracranial monitoring, we don't do have bolts or other things in this because that causes more problem. Coagulopathy, as many of you know, that there's a clinical, despite very high INR, the data that they have significant bleeding complications are still very rare, fortunately. So you don't transfuse with INR alone. And then although we don't have ROTAM available, this like, thromboelastography, they have it in the OR. But, when there was the one study we did that, it was not that like the risk of like bleeding or ROTAM was like mostly normal in acute liver failure. And there's an imbalance between von Willebrand factor. And if that imbalance is there, the outcome and bleeding risk is higher. The infection is common up to 80% and responsible for 40% of the death. And that can sometimes happen. The liver is recovering, or we have seen post transplant because the patient was intubated, acute liver failure, and a fungal infection. Therefore, we do cultures regularly. And as I mentioned, we use moxifloxacin as a prophylaxis. Unless someone comes in sepsis, we use broad spectrum. And although this one study did not show the prophylactic antibiotic, but if someone had bloodstream infection, the mortality was pretty high in these patients. The hemodynamic wise, that systemic vasodilation is in any liver conditions. And so if someone is really hypertensive, most of the time ER already given them, we don't give them extra fluids. But if you wanted to use vasopressor, norepinephrine first, and then you can use vasopressin as the next. And to keep the cerebral perfusion pressure, we wanted to keep the MAP goal greater than 75, sometime around 80. So that is one of the other aspect of our management. And renal dysfunction is the major indicator also for poor prognosis in that regard. And as I mentioned, especially with APAP cases, but in overall 40 to 80%. And the risk, obviously, the age, the older age, the APAP, if they have underlying infection, the risk is much higher. And what are the potential benefits? So it's not like intermittent hemodialysis or the thing. In our network, UCSF were very aggressive. So almost all our patients with ALF, but 30% in our group has it. So it also help you with temperature control. It can remove the ammonia, so you work with it. It can regulate the sodium balance, so that is other aspect. And then so these are the much benefit out of it. And more importantly, you keep the intravascular, keep the volume status down, but there is no prospective randomized controlled trial that shows that it improves survival. But definitely, this is something we start right away and we call our renal colleagues as soon as an acute liver failure patient comes in. Now, lastly, I think about the liver transplantation that when I was talking about like why it's important to have a correct, not differentiating between acute and chronic liver failure, that many of these patients if they need if not needing a transplant but at least will be listed, and the listing status is what we call status 1A, meaning that they will be highest in the whole region. It's not the MEL score, and so we are in region 5. So this patient, if they listed a status 1A, can get organs from the whole region. So ideally we have seen like unless something else is happening, the size is that we can get an offer for transplant within 24 to 48 hours and sometimes even earlier. But to qualify for status 1A, you have not to showcase that they have acute liver failure, you need to say that the encephalopathy developed less than 8 weeks after the onset. These patients obviously need to be in the ICU with one of the following: the INR of greater than 2, then either mechanical ventilation or CRT. So you need to fulfill all the criteria before you can list them for liver transplantation. So that is also very important to remember. And there are some of the there's a smart phrases that the attending has to put it in before someone can list them. Now, in summary, acetaminophen is and remain the most common cause of acute liver failure. Always remember the etiology and coma grade are the two most important indicator of prognosis. And cerebral edema infection are significant causes of death, so that is what we are focused. And since the better ICU care, amazing team that we have in the ICU and option for liver transplant, the survival is much better. Especially, I feel that at UCSF our survival is like 90 or even higher as compared to overall. But because of better supportive care, we use NAC in almost all the patients. We start early CRT and we start management of intracranial hypertension, which is very critical to survival. it does require specialty care and so involving. And if patient needs a transplant, but transplant center has to be part of it, and transplantation is a centerpiece. Obviously, there are some patients who are not candidate, and we cannot bring them all that. We do need more prognostic tools to identify, but acute liver failure study, that prognostic tool is, I think, pretty reasonable, and we do use it. And but always in the end, recognize the hallmark of acute liver failure. You may not see, but sometime in the boards they love this. So development of without pre-existing liver disease, someone with a development of coagulopathy with hepatic encephalopathy is the definition of acute liver failure. And I'm open to any question. I'm glad that I finished it on time and gave you 5 minutes.